it adds a few more layers of complexity. So went down to, okay. As we know, in Bangalore, we have the National Law University, and so we have some friends there. So we discussed, so they have a very nice collaboration between the National Law School and the Indian Medical Association. So they're working together on how to reduce litigation, especially against doctors. So there are a few points that I understood from interaction with them. Firstly, even though we think video consents may be like a really cool thing to do and maybe protect us against many problems, still under law, the written word is sacrosanct. So that's the first important take home that I got. And except in emergencies where, and we don't deal with them too many because we are in the field of ophthalmology, but if you are in accident and emergencies kind of setup, you can actually even operate and maybe even end up not being successful, making the patient survive and still not be medico-legally liable. So other than emergencies, consent is absolutely essential. The own language part is something that we don't really look at. We think our very fancily worded English language consents, which deal so much with the language and the science, is enough. But quite clearly, the law will not look at it favorably if we've not explained it, at least in proof of it, that we've done it in the local language. What is the absolute foolproof method of getting around this problem is to firstly get them to understand it in the local language, sign it or sign a consent that is in the local language, preferably also translated in English to prove that you've done the right science behind it, and then have that signature and the fact that that person or patient has agreed to the consent taped on video. That is supposed to be the foolproof. Now, do we do that in all cases? We certainly don't. But certain clinical trials, for example, demand that we have video consent. So this is something to keep in mind. So this is like the final field. Like if you can actually end up doing a written followed by a video one, then that's the only one that is foolproof. And that is the journal in which they published this professional code of etiquette and ethics in 2002 and apparently not been revised since. So in law, there are just two types of consents, implied and expressed. So if a patient walks into your office as an ophthalmologist, the fact that you are examining his or her eye is implied. But it is not implied that you're going to suddenly start auscultating that patient. In other words, if a patient enters a gynecologist's office, certain examinations are considered implied because that's part of a gynecological procedure. So the moment you overstep what is considered normal examination methodology for you, then you have to take consent. And this does not have to be written. For example, Mr. So-and-so, can I look into your eyes is enough. And if, of course, that patient says no, then why did he walk into your office? That's the next question. But you have to take that one oral consent even when it is implied. And I think all of us do that. Many of us who've done foreign exams know that you will fail if you don't introduce yourself and say that I want to examine your eye or whatever. So, and it also falls on the fact that if the patient comes in, the patient is supposed to follow the diagnosis as well. And expressed can be two types, oral or written. Written, of course, we'll come to. So there are only two prerequisites according to law. Firstly, the person giving the consent has to be mentally sound. Now, obviously, this does not apply to pediatric patients because they may be mentally sound, but they may be even pre-verbal patients. So we'll deal with that. And then informed, so all information that will prevent a case of negligence. It is so gray zone worded that really how much information is enough information. That's where the lawyers really score over you because you're an expert, but you won't be able to defend that in court. Now here is a wonderful article, real consent and not informed consent is applicable in India. Now this is something that I wasn't aware of and I discussed it with my lawyer friends. So what is a real consent? There are only three aspects. Firstly, there should be enough knowledge, and we can debate on what enough is. Second, they should have the capacity to understand, which means they should be mentally not challenged and they should not be inebriated or something like that. And third, they should have done it voluntarily. So these are the only things. So they call it the DCV thing. Disclosure, capacity, and voluntariness. And this is based on the United Kingdom or the UK court system, and our Supreme Court uses this. Whereas the informed consent, which we all believe is the one that we have to take, has so many more layers. So there we talk about the nature of the disease. We want to tell you what problem you have, what our treatment will do, what are the other forms of treatment, what happens if my treatment doesn't work, how am I going to take care of the complications if it goes wrong, and many other things we keep on adding into our consent, thinking that it is foolproof. And this has been made in the United States to prevent litigation. So the UK one protects patients, the US one protects doctors, and this is exactly how the law looks at it. Now here is the most important fact that came out of our discussion with the lawyers, that the Supreme Court wants of India in 2008, and I believe this hasn't been revised in the past 12 years, only wants us to take a real consent. Which means you don't have to add all of those layers that we've been adding. We are doing it for our own protection, fair enough, but you're not going to be held against that if you've not done it, because I'm just going to read out from that. But if the medical, so we have, however, consciously, and they're referring to that case, but if medical practitioners and private hospitals become more and more commercialized, and if there is a corresponding increase in the awareness of the patient right among the public, inevitably a day may come that we may have to move towards the Canterbury system. The Canterbury system is the informed American system. And the last line, but not for the present. So of course the Supreme Court falls back on its own precedents. So if you're caught in a case between now and the next revision, you can always say that, Honorable Court, you had said that the real consent was enough. I'm not saying that you don't need to take informed consent, but just be aware of your legal rights before you get pushed into something. So this is a LASIK consent, and my colleague Sharon was supposed to talk about a bit about it. Pooja, you want to?
So what, like we all know what we take in the LASIK consent, like everything has to be explained about regression, ectasia, infection chances, or inflammation, or when in future you may get cataract, presbyopia. So all those points are important. But off lately what we have been seeing is a lot of patients come back with glare, halos, and regression. So are these patients actually having glare and halos? The answer is no. We are in a millennial generation, which I'll be also touching upon when I talk about the psychiatry couch. So we are in a millennial generation when all the youngsters, including they are always on mobile phones, they're always on computers. A lot of IT people, they get operated for refractive surgery. So what is important and what we have added is, because when they come back with glare and halos, few of the patients, we did an orthoptic evaluation. And what we saw was that a lot of these patients had vergence and fusional problems. So that's when, and then they need orthoptic evaluation and orthoptic exercises. But at that point of time, how are you going to explain the patient that this is not the regression? This is not the power has come back. You have to tell them that this is the muscle imbalance, and that is maybe because of your profession. So what we decided that, when the patients later on come, back with all these problems, we'll rather add it in our consent. So this is a very small consent where we have added that, some patients may have a pre-existing eye imbalance and muscle imbalance and orthoptic related issues, which is missed because a lot of them are myopic and they might not have a problem before surgery, and we cannot pick up. So after surgery, if any of these complaints you come back with, you might need an orthoptic evaluation and exercises for the same. So now they are not going to understand what orthoptic is. So you, in a very simple language, you can explain them that it is, it's a physiotherapy for your eye. So this is what we have added in a consent, and when we are counseling the patients also, we make this point very clear. So the incidence of unhappy patients have reduced by around 70%. So this is the importance of one latest thing which we have added in the LASIK consent.
Thank you, Pooja. I also want to add that the LASIK department gives out this consent a day or sometimes many days before the actual procedure, and takes a signature noting that the patient has received this consent. So there's proof that you've given it to them, and the patient is told, read it and come back if you've made up your mind to undergo surgery. And I think this is important for surgeries like these, where it's not other kind of surgeries where the patient demand is also very high. And when they come back, it is now implied that they have read it, understood it, and cleared all their doubts, and then they sign it and give it in. So I think that's really important. And I know that Sharon put this in here because she said that in very high-risk cases, I'm not sure which one this is here, but in very high-risk cases, where failure, especially for grafts and so on, is more likely. Handwritten consent is also what they add into the file. So in addition to all of this, it does not have to be the handwritten of the patient, I believe. Even the doctor can handwrite it, but it's read out to them, and then when they agree, they sign. So this is something, an add-on, because this could help you in the code. I'm just coming to a little more familiar retina ground, so I'll take it from here. Well, I'm just going to discuss consents more generically, and I'm not really trying to give you consents here for any of the procedures I'm showing you. But let's see if there's a standard format. So fortunately, I don't know how many of you all are aware that AIOS has a book of consents that they've sent out to members. Has anyone not seen it? Okay, good. So yeah, so I guess that takes care of many of our problems, because you can fall back on the society saying this is what the society prescribed. So like this one, for example, the intravitreal injections that we use in our institute, we've just downloaded the VRSI form, and then we've added a few things. So the addition is something that you will have to customize for your own institute. So of course, in an NABH institute, you want to add what they call a controlled number. And here, so this is an example of an informed consent. So here you're adding in the indications, and then you're talking about regulations and how that it may have not been off-label and so on, the limitations of, so this is almost like a short answer in a question like in an exam. You don't really need to inform this to the patient, but this is where I think VRSI is taking a very strong stance, saying, these are the facts that we know, this is the lacuna in the information, but this is still good for you, and this is what we are going to do for you. And that's exactly what we are doing. And of course, bleeding in the eye, these are, as you can make out, written in language that can be understood. We are not talking about retinal hemorrhages or choroidal hemorrhages here. We're talking about bleeding in the eye, and that could be anywhere from conjunctiva to retina. And this is exactly the language in which it has to be communicated to the parent. So look at, to the patient. Glaucoma, increased pressure in eye, and so on. So we're lucky that VRSI has this consent. Now let's go on to what I was talking about in a minor patient. So the best example for me would be ROP. So obviously, few things change? Firstly, obviously you'll need a parent signature. We believe in taking both parent signature, and sometimes there's only one parent, so that doesn't matter. You can have another relative and mention the mobile number and the relative patient of that. So what are the additional points that we've added? So this is consent to actually examine a child, just a regular ROP screening. It could be indirect ophthalmoscopy, it could be imaging, this doesn't matter. This we have created on our own because there was no precedence. The laser ones, a lot of formats do exist. So what have we added? So let's go over the steps. The diagnosis, that is ROP. What are the chances of success? Obviously depends on the type. The failure, obviously, what are the possible complications? Why do you need to long-term follow-up? What kind of anesthesia and approximate duration of the procedure? And what is the need for follow-up? All this should be told to them, and that's why it's included here. Now one more layer of difficulty. So you have a minor patient in which the treatment is a off-label use. So here now you're giving an intravitreal injection. Of course we give it, but there's no provision under law that can be protected if something goes wrong. And this is like once in every week there is a query in the Indian ROP Society, give us a consent, give us a consent. So this is now using that line of what the Supreme Court said, we are going 5 steps ahead in this. We are going informed plus plus. So here we are talking about, we directly tell them that it's an off-label use, we talk about the disease, and then we add some what is called in law a theoretical construct. So we say this is not the sole therapy, you might need to undergo another injection, maybe another laser. Even if it's successful, what it means. Success to you and success to a mother may be different. For a success for a mother means good vision, but an APROP baby may have bad vision because of some brain issues. So all of that has to be kind of constructed here. And the approach is fairly defensive. If you read some of the lines here, it says, off-label, I told you so approach. The I told you so approach is to say that, I told you that things can go wrong, rather than take a positive approach saying, things are usually going to go right. Because that is the back foot you have to take when you're taking an off-label. And this would apply if you were doing procedures that were experimental, which are not under the gamut of a clinical trial. So you will have to go this extra mile for these kind of consent. And then of course talk about the dosages. In this case, we don't even know what is the right dosage. So you have to mention that. And whether you're going to do both eyes on one day or on subsequent days, this is a big issue, because what is the legality if both eyes have endophthalmitis in an off-label use? So this is something that you need to explain to them, that are you willing to get it done on the same day or consecutive days, and the unknown systemics. But finally, you must end like this. So everything possible will be done to ensure that the disease is treated in the best interest of the child. There has to be language like this which says that you are doing it in good faith. And this is not written here to make it sound like a nice consent. This is a legal requirement. Because when you're doing off-label, you have to prove that you're doing it in the person's good faith. With the limitation of knowledge, that's how science is advanced. So that's all I actually have to say about consents. We'll probably go on to the next talk. If anyone has questions at this point of time, I'd be very happy to take it. Oh, I think AIOS would have probably sent it to your home address, but you can check with the AIOS office. It's one of the AIOS publications that they have. It should also be available on the website. Thank you. It's available outside the trade.